So I think here shortly we're going to have the session leaders come up and give their awards for first and second place for each session, and then the trauma competition, the award. But I just want to say thank you to everyone who's attending. I want to thank Gordy Wisbach. He's the co-chair of this session and or this meeting, and Rob Lim was the chair. And if everyone knows Rob, I mean, he's really the person that took this off the ground and made the military working group what it is. He received a very nice award from SAGES. He's unfortunately deployed to Afghanistan right now, so he couldn't be here. And so Gordy kind of took up the mantle as the co-chair and really made this work. So he did an outstanding job. Thanks to everyone attending. The abstracts were outstanding. I think it was, I mean, last year was good, and this year is the second year. I think it was even better. Our invited talkers, Captain retired Rhee, and then yesterday with Colonel retired Peoples and Colonel Lau, they were all fantastic talks and the abstract content. Thank you to all the session leaders and everyone on the committee, the program committee for all their hard work to get this happen. And the surgical jeopardy with Stacey, that worked out great yesterday. I know Madigan won again. Did they win last year? I don't know, but anyway. But really, it's the thanks is the SAGES. The SAGES organization gives us the opportunity to do what we do and gives us a platform, especially with kind of the funding going down with our service-specific meetings. And it's nice to have a tri-service. And Dr. Schwartzberg, I talked to him. He's an ex-president. He's the one that really worked with Rob to get our working group going several years ago. And his question was, do we get the tri-service that we wanted? And I told him, you know, resounding yes with all the representation we had. And that's why, and the fact that every session we had a session leader from each service, the Army, Navy, Air Force, and they did a great job. So again, thanks to everyone for their hard work, and I'll turn it over for the awards.
All right, so for the basic science session, we have two awards, like all the other sessions. They are named awards that have been given at prior service-specific conferences that we've been able to carry over to the Society of Military Surgeons conference. So the second place award for the basic science session is named for Colonel Jeff Kavulius, who is a much-loved member of the Army Medical Corps. Graduated from USUS, matriculated through Walter Reed, and was deployed in the first Gulf War. He had a very long career with the Army, touched a lot of lives, was program director and chief of surgery at Tripler at the end of his career, and I think probably a lot of people in this room recognize his effect on Army medicine. So without further ado, I'll present this to, for her work, hyperbaric subnormothermic perfusion maintains tissue composites ex vivo beyond the limits of cold ischemia. This goes to Dr. Sharon Lawson from UTESCA and the USAISR. The first place award is named for Lieutenant General Paul Myers. Lieutenant General Paul Myers started his career in the Army and later joined the Air Force in 1951. He was trained as a neurosurgeon and eventually progressed to become Surgeon General of the Air Force. His support for Air Force surgery was profound and extended well beyond his retirement, including the support for the Society of Air Force Clinical Surgeons. And so this award is in honor of him. This will go to the suspension of biologic time and fatal traumatic injury preliminary results from the Biochronicity Project for Captain George Black from Madigan.
Good afternoon. For the general surgery session, we have a named award for Brigadier General Robert E. Lee. He was a, not that one, he was a Army Air Corps surgeon that joined the Army Air Force in 1949 and eventually rose to the rank of Brigadier General. He was one of the founding members and very instrumental in the formation of the Society for Air Force Clinical Surgeons and remained active throughout his active duty time as well as in his retired life. This award is going to be presented today to Captain Avery Walker of Madigan Army Medical Center for his presentation, Do One, or See One, Do One, Teach One, an analysis of chief resident assist cases under varying levels of attending supervision.
I have the pleasure of awarding the Vice Admiral Robinson Award. Vice Admiral Robinson essentially achieved everything you could possibly achieve as a surgeon in the military, including being a staff surgeon deployed on a carrier several times, a fellowship in colorectal surgery, the chief of colorectal surgery at Bethesda, chief of general surgery in the residency program at Portsmouth, and then his service at the BUMED at the Navy Board in multiple capacities, finally commanding the National Naval Medical Center, and then the culmination of his career was the 36th Surgeon General of the Navy. So about as many accomplishments as you could possibly achieve as a surgeon in the military. And based on that, this award goes to the General Surgery Award for the project, the feasibility of FLS mastery training standards applied to lower cost differential training platforms. Dr. Mercy Wagner from the Walter Reed as well as USIS. Congratulations.
For the second place award, we're awarding this the Captain Peter Rhee Award. I can't add much to what he just showed us. However, I did have the opportunity to have him be one of my mentors as I finished my residency at Naval Medical Center San Diego, and also ended up enjoying his tutelage as I prepared, actually when Matt was a fellow at USC, to get my team ready to go for Iraq. And we're awarding the second place award for the trauma session to Captain Michael Clemens for his combat pancreatic injuries.
All right, and I want to add thanks to, again, to Yang and to Gordy for putting together a great meeting. And it's always great coming to these and seeing everybody year after year. I think it really highlights how military, even tri-service, is a small community, but it's an incredibly deep community. And if you look at the people these awards are named after, two of them are leaders that I think have influenced many of us in the room who were taken from us too early, both by cancer. One was the one we're honoring here is Colonel David Burris. Actually, the first place award for the trauma session is named for him, and also the Army American College of Surgeons Committee on Trauma Prize is also named for Colonel Burris. Just a show of hands, how many people in this room have been influenced by Colonel Burris during his career? So pretty impressive. He was the chief of surgery, Norwich professor at Uniformed Services University, was a tireless advocate for the students, residents, military medicine. He was our face at most of the major trauma societies. So I think it's quite an honor to receive this award and to have it named for him. And he was fortunate enough to see this award first given before we lost him. So Tom's going to present the award, the Colonel David G. Burris Award for the first place in the trauma critical care session.
And that's going to Captain Daniel Herder for his complex blast injuries and Daniel, I'm sorry. Daniel Herder, complex blast injuries of amputation to perineal involvement.
All right. Is anybody here from her program? Okay, we'll get the award to her then. And then next we'll present, both the Army and the Air Force are using this meeting to select our resident paper competition winners for our states in the Committee on Trauma. As some of you may or may not know, the Committee on Trauma is broken down into regions, and then each region is broken down into states. The military has its own region, Region 13, and that includes the Army, Navy, and Air Force states. So and each of the states picks a winner in basic science and clinical from their resident paper competition, and those go on to represent the states at the region competition, and then the winner from that goes on to the national COT competition at the spring meeting in March. So we'll start with and again, this is named after Colonel Burris, who I just described, and again, it was an honor that we could name this award for him. The first will be our winner in clinical research for 2015. The winner is Captain Michael Clemens for his work on combat pancreatic injuries. And the prize for this is a certificate and the award, a copy of the Frontline Surgery book that many of the people in the audience put together. Congratulations.
Thank you very much.
And then again, remember this also is your invitation to present at the Region 13 competition, which is most likely going to be held at the American College of Surgeons meeting in October. And then our basic science research winner is Captain George Black from Madigan Army Medical Center for his work in the biochronicity project. Okay, and Stacy's going to present the Air Force winners.
Okay, to be eligible for this competition, you had to be in the Air Force, and you had to present a trauma paper. The first winner is for the trauma clinical paper, which goes to Captain Danielle Herder for her paper, Analysis of Coalition Soldiers Sustaining Bilateral Lower Extremity Amputations with Perineal Involvement Secondary to Improvised Explosive Device. Is Danielle here? Okay. The prize is an all-expense trip paid to the American College of Surgeons to present at the Region 13 competition. For the trauma basic science paper, the winner is Captain Rachel Russo. Partial Reboa minimizes distal ischemia while preserving central circulation in swine. Congratulations.
All right, excellent. A lot of my comments I was going to make, Colonel Choi had already mentioned, but I just want to re-mention that it's really a really great symposium due to a lot of effort on a lot of the session chairs. There's a lot of teleconferences, and the call for abstracts. A lot of great abstracts were submitted. It was really a good breadth of presentations here and lively questions. So I really want to appreciate everybody's efforts in doing that. And we would certainly not be here, as Colonel Choi mentioned, without Colonel Lim's leadership initially, and we wish him safe time over in Afghanistan, a safe return, and as well as, of course, SAGES. So SAGES has been paramount to allow us. They have a lot of infrastructure that's really facilitated, allowing us this space, and really the leadership of SAGES has allowed this to happen as well. So it's important, if you're not a member of SAGES, that's something to really consider, becoming a member of SAGES, kind of continue to be involved with an organization that's been very supportive of our efforts. As well, I want to make another plug for, this is the conclusion of the 2015 Military Surgical Symposium. However, there is still a very relevant military event at 4 o'clock, Lessons Learned from Military Surgeons, and several of the members in the audience will be presenting very relevant topics at that symposium. So again, thank you everyone for your involvement, and enjoy the rest of the conference.
All right, well, good afternoon, everyone. It's 2 o'clock. We're going to get started. We have a pretty good-looking group here this soon after lunch, so thank you all for coming. My name is Greg Dakin. I'm one of the program directors for this session, along with Jonathan Dort. I would like to welcome you to our acute care session. We're going to talk about various issues that are pertinent to all of us who take care of acutely ill or sick patients in the hospital. I think the format of this session, we have very brief presentations by it's actually 7 presentations by 6 presenters at this point. We'll do all the presentations quickly, trying to keep everyone on time, and then we'll save the remaining time at the end for questions. And hopefully you're all familiar with the app that you can send us an email question, or you can certainly come on up to the microphone. So without further ado, we'll get started with our first speaker, Kozar Khwaja, who comes to us from McGill University in Canada, and he's going to speak on the effects of pneumoperitoneum in sick patients.
Thanks. Just put that further away. Okay, good. So I'd like to thank SAGES and the chairs of this session for allowing me to speak. Okay, so I have no disclosures. At the end of the day, I think the major point here is that at 2 o'clock in the morning, when you have an ischemic bowel and you're taking the patient to the OR, you know, the bottom line is that we take a step for reflection, a moment to reflect and take a pause. And I want everyone to try to think about whether or not putting a scope in that patient is actually doing more harm than good for the patient. And that's the bottom line. And as we try to push the envelope with our minimally invasive approaches, and we bring something that we're very comfortable in our elective practice, and we bring it at 2 o'clock in the morning in a patient who's physiologically deranged, we have to take that moment to reflect. And so what I'm going to do is I'm just going to talk about that, and we'll go over the physiological impacts of pneumoperitoneum and how that can affect our patients, our emergency general surgery patients. So let's just start with the first case. So this is a 65-year-old or 66-year-old female who presents to the emergency room. She's post-op a laparoscopic sigmoidectomy for adenocarcinoma, and she underwent the enhanced recovery program. She's had a stent before, and now she presents to the emergency room with hypotension. And she has localized lower quadrant pain. So this is your x-ray, and you see some free air below the diaphragm. And so the question really is this: who would take this patient to the operating room and put a scope in? And we're suspecting a potential leak. So who would put a scope in? Okay. All right, so let's go to the next case. So now you have a 69-year-old male in the ICU. He's post-op day 1 from a mitral valve repair and a cabbage ×2. He comes out with an intra-aortic balloon pump. And these are the patients that we see at our center. And you get a consult that says, please rule out ischemic bowel. And the lactate's 8. And the patient's on significant pressors and is on inotropes, and the cardiac index 2.2. And they do a CT scan, which is inconclusive, and the lactate's still 8, and the patient's metabolic has a derangement of acidosis and a creatinine of 180. So who in this room would take this patient and, you know what, just put a small scope in? Because these are the cases that cardiac surgeons ask us at our hospital. Just put a scope in, take a look, and if it's ischemic bowel, you guys deal with it. Okay, so we have one person. Okay, so we're going to go through sort of the impacts of pneumoperitoneum on physiology. And these are the 3 different types of people that we see. And I think the point is that they're not the same. So we're all comfortable with the healthy patient undergoing minimally invasive surgery. You know, that happens from 7:30 in the morning till 5:30 p.m. And then there's another class of patients who have comorbid illnesses who also go minimally invasive surgery. And these are patients who are sick, but you still put them on your elective practice and you do your procedure. And let's not confuse this group with the patient who comes in acutely ill. Okay, so they're not the same population. The critically ill patient who needs surgery in the middle of the night has to be thought differently from these 2 different groups. Okay, so one extreme is the elective hernia, and the other extreme is strangulated hernia. Okay, so I think to ensure that the minimally invasive procedures are performed safely in emergency patients, we need to understand the physiological effects of laparoscopy and positioning of the patient. And we need to understand the physiology of the critically ill patient as well. Okay, so there's significant data describing alterations of physiology in elective healthy patients, and there's not really a lot of data with the effects of pneumoperitoneum on acutely ill patients with respect to their derangement and physiology. Okay, so what are some of the cardiovascular response to pneumoperitoneum? And these are the things that I think we all learn I guess during residency, and we may not actually we may not think about it in the middle of the night, but well, first of all, there's an increase in intra-abdominal pressure. Patient position can actually affect preload and afterload. There's also the CO2 absorption. We'll talk about that a little bit later. There's the ventilatory strategy. There's intravascular volume. There's also the pre-existing cardiovascular, cardiopulmonary status of these patients. These patients who come in with the ischemic bowel, who have severe vascular disease, do not have a normal cardiovascular system. And there's also the neurohormonal response, and of course, they're usually on tons of medication. Okay, so I know this is a busy slide, but the most important line I wanted to show was the TEE. So if you look at TEE images, during pneumoperitoneum, as you can see, there's an increase in the mean arterial pressure, there's an increase in SVR, there's an increase in CVP, and there is a decrease in cardiac output. So if you have a patient who is in severe septic shock going to the OR, already you have a derangement of their cardiac output from myocardial depression from sepsis. But if you're going to then on top of that add pneumoperitoneum, you will decrease their cardiac output. So what are the respiratory effects? Well, there's definitely some effects of the CO2 gas that we use. There's a rate of absorption that's actually dependent on the gas solubility. And what we find is that the peak EtCO2, end-tidal CO2, and VCO2 are actually greater in the extraperitoneal insufflation versus the intraperitoneal insufflation. And at the end of the day, the actual absorption of PCO2 of CO2 really depends on the patient's cardiovascular pulmonary disease. How well are they able to eliminate their CO2? And so we know that the minute ventilation increases on these patients, and we can actually have hypoxemia that can occur due to hypoventilation or even intrapulmonary shunting, and of course from reduced cardiac output. We know that there's a decrease in FRC and lung compliance, and patient positioning is a factor. So whether you put them in Trendelenburg or reverse Trendelenburg, this clearly affects not only lung mechanics, but also volume return and afterload. So now, we know that there are some positive effects of pneumoperitoneum and laparoscopy in patients compared to laparotomy. And these findings we find postoperatively, right? So there's a reduction, there's a smaller reduction in FRC, there's a better FEV1 in patients who undergo laparoscopy. And of course, there's early mobilization. Okay, this is, I think, an important table I think that we should always keep in the back of our minds. These are the regional effects of pneumoperitoneum on the various organs. So in the brain, CO2 can increase cerebral blood flow, right? It can also increase intracranial pressure. That's why a lot of us who do trauma, we think that this is an absolute contraindication to doing a diagnostic laparoscopy in any patient who has a decreased mental status or you're suspecting head injury. There's obvious effects to the liver. There's a decrease in portal vein blood flow. There's a decrease in basically hepatic blood flow in general. And there's also an effect on gastric and small bowel perfusion. Now we do laparoscopy routinely on colons and small bowel, but in the middle of the night, when you're dealing with someone who you're trying to solve ischemic bowel, or you're trying to address ischemic bowel, don't forget that your pneumoperitoneum is also altering the patient's pH and is also altering the blood flow to the bowel. Of course, there's also kidney derangements, as you can see there. And clearly, if you're going to the OR with someone who has an elevated creatinine, keep that in mind, that you're actually decreasing perfusion to the kidney during your time of pneumoperitoneum. There's a number of immunomodulators that have been found. And of course, I'm not going to get into the details with that. And of course, there's a whole list of complications that we all know with respect to pneumoperitoneum in laparoscopy. So at the end of the day, I think we need to recognize the challenges in acute laparoscopy. The patients are sicker and they're critically ill. And they may be in shock, and that could be septic, hypovolemic, hemorrhagic. They may be cardiogenic. And someone that you're taking to the OR for severe sepsis, for some sort of a bowel ischemia, they also they can have cardiogenic effects of that sepsis. And of course, there's the metabolic acidemia that's compounded by the lactate generation. So these patients who are acidotic from their sepsis, and now you've introduced CO2 in their system, and if you cannot keep up with their minute ventilation, this can further aggravate their acidemia. And so this is your typical definition of shock. That's any impaired end organ perfusion. And so you have to sort of think about that when you're going to take your patient and put the scope in. There are a number of comorbidities that are pronounced in critical illness, and of course diabetes and glucose control is much more difficult in sepsis. There's acute on chronic renal failure syndrome. There's patients who have coronary artery disease can further have an increase in myocardial demand. So this is obviously, we always say this, just because you can do it, it doesn't mean that you should. And so in summary, I think these are the questions that we need to ask ourselves when we take our emergency general surgery patients. What will the physiological impact be of the minimally invasive surgery? What are the potential benefits of laparoscopy in your patient? And what are the potential complications of pneumoperitoneum that your patient can actually tolerate? So patients who show evidence of shock, hyperperfusion, or end organ dysfunction, I would suggest should not undergo laparoscopy. And I think that should be the overall rule that we should be teaching our residents. Thank you.
Thank you very much. Okay. All right, thanks very much for that talk, and feel free to shoot we're going to try to get to the questions at the end, so feel free to use the app and shoot them. We'll get to them, as many of them as we can. So all right, I will give the next short presentation. Again, my name is Greg Dakin. I work in New York City. I do about 50% bariatric surgery, so I was going to speak on what types of emergencies that the acute care surgeon should know in terms of bariatric surgery. So whenever I give a talk about the complications or the acute emergencies of bariatric surgery, and there obviously is a laundry list of them that can occur, I feel an obligation to mention again that in actuality, the relative frequency of any of the very bad complications from bariatric surgery is very low. In some of our own data, even the overall composite endpoint of very bad outcomes, death or DVT, PE, leaks, and reintervention is very low, maybe 4%. Chance of a DVT or PE, certainly under 1%, dying maybe around 0.3%. But nevertheless, there are a good variety of complications that can occur. And unfortunately, these complications may occur when a patient is outside of the hospital that had their surgery. So they may find their way to a place that doesn't have bariatric surgeons or where you may be asked to take care of them. The first thing you're going to do is look at when was the operation. That will give you at least a starting point to help differentiate what of that long laundry list of complications you're going to be dealing with. Obviously, if someone comes in a year after surgery, you're not going to be thinking leak. Leak is something that happens in the acute postoperative period. DVT can occur or PE can occur anywhere in the early postop period, even up out to 30 days, probably even a little bit longer. So it's probably always on your differential, but that's a good way to start when you're evaluating patients that come into the emergency room. And obviously, you have to be a little bit familiar with the basic surgeries that we do. I took it for granted that the SAGES audience is fairly familiar with at least the 4 main surgeries that are currently in use here in the United States: gastric bypass, lap band, something called sleeve gastrectomy, and then certainly less common duodenal switch. So I won't go into the details of those operations. I think we all have a good baseline knowledge, but obviously depending on the surgery, you're going to have a different set of diagnoses in mind. There are some key principles to keep in mind when you're evaluating a bariatric surgery patient. Some of them, in some ways, are a little different than many of your general surgery patients. They have a little bit different or less minimum physiologic reserve. Certainly pulmonary function is a little bit affected. Physical exam can be difficult in the obese patient, maybe a little bit less reliable. So these are all things to keep in mind. And lastly, we think it's important to act quickly. If you think an operation is necessary, delays in surgery can be more harmful than they might be in the general population. Also remember that a bariatric patient can have non-bariatric problems too. So don't forget about appendicitis, cholecystitis, any of your gynecologic acute problems can occur. So a brief word on a patient who comes in with septic symptoms. Fever, tachycardia, hypotension, and the like. The differential is wide, but there's certainly some very concerning things that could be going on, and some maybe not as concerning, even though your patient looks sick. The real question that I get asked a lot is, what's the role of imaging? And everyone wants to think when you see a patient you're worried has sepsis, you may be thinking about a leak, and many people would rush to get into an upper GI. That may not be the most useful test, certainly not going to be very helpful if it's negative. Certainly it's tempting because if it's positive, then you know. But there's a lot of other things that can go on, leaks from more than just the proximal anastomosis in the case of a gastric bypass. So really CT of your chest, abdomen, and pelvis is probably going to be the most widely used and most useful diagnostic test. You can get it PE, you can get it leaks from the different sites. Just remember, there really should be, for an operation that was done laparoscopically, there really should be no free air, at least 1 day after surgery, and minimal, if any, fluid in the abdomen if everything's going well. So these are the complications or acute problems that I chose to focus on. There probably are some others that we could deal with, but in a short period of time, I thought these would be the most important. Bleeding can certainly happen, and that's a patient who's gone home and can come back in with bleeding. It's going to present one of 2 ways, usually with hematemesis, so bright red blood vomiting. And then again, that's going to depend on your surgery. The sources are either the gastric pouch or the proximal anastomosis in a gastric bypass, or the big long cut line with a sleeve gastrectomy. Your first option always is to treat the patient conservatively, resuscitate, transfuse as necessary, see how they're doing. But that may not work. And so then your best course of action is to do endoscopy to try to control the bleeding. And what I want to stress is that this endoscopy should always be done in the operating room with the patient intubated and you standing by. They can have difficult airways, not universally, but challenging airways. You've got a lot of blood in there. You do not want to be trying to do any sort of endoscopic intervention without having a secure airway. Your next course of action will be laparoscopy, and you can oversew the proximal anastomosis or the gastric pouch. If they come in the other way with bright red blood per rectum, again, the source is going to be a little bit different. Either that, in the case of a gastric bypass, could be the remnant stomach, or say your distal staple line of the gastric bypass, the jejunal jejunostomy. They can present later, years out, with other problems, just routine peptic ulcer. So again, treatment is conservative. At first, try to resuscitate the patient. A lot of these may stop. But if you need to, you probably will have to go to the operating room for oversewing. Endoscopy is going to have less of a role in this case, especially if it's an acute bleed after surgery. If they're more chronic, you may want to investigate some other standard bleeding evaluations, such as even a bleeding scan. Leak is the big dreaded complication for bariatric surgery. Again, doesn't happen very often. Nobody wants to see this x-ray on the morning of post-op day 1. That's a sleeve with a gigantic leak out to the patient's left there. They are infrequent, maybe 1% after gastric bypass. I think the number 1 to 2% after sleeve. A very high rate of mortality when people leak still. There's no consensus algorithm as to how these should be treated. But the one thing for sure is that it really may need to be treated by a non-bariatric surgeon. Most of the leaks get diagnosed after the patients have been home. Probably around 7 days is the median diagnosis, and our patients are usually discharged on hospital day number 2 at this point. So many of these patients, if they get sick, if they have a leak, they will get brought to the nearest hospital, not back to where they had their surgery. Leaks get classified. They usually present with fever, tachycardia. Your diagnosis test of choice is CT scan. And then your treatment is going to depend on the patient, whether it's an acute or chronic leak, whether it's a stable or unstable patient. But all your general surgery concepts apply. You have to treat the patient, resuscitate, explore, wide drainage, repair if you're able, and with really a strong emphasis on enteral access. If it's a patient who's going to be sick for a while, you need to be able to feed them. With an acute unstable leak, so again, you want to provide drainage, you can repair depending on the operation. If it's a sleeve, you might be able to revise it or convert it to a gastric bypass. Chronic leak, you have some other options. Certainly stents have come into play. I think they're a little bit more useful for the acute leak. This is a picture of what one would look like. If you have that technology, it can be very useful in managing leaks, particularly with sleeves, because they tend to migrate a little bit less than in the case of a gastric bypass. And there are some other endoscopic interventions that many people may have and you're familiar with to try to seal up a leak from the inside. But the key is to treat the patient. If they are behaving septic, you need to get in, get drainage, resuscitate, and also do your very best to try to place a feeding tube. Obstruction is another common problem, certainly more common than leaking after bariatric surgery. There can be many different sources. This is actually a picture of an intussusception, but you can have small bowel obstruction, gastric obstruction, obstruction in anastomoses. Obviously, a patient is going to come in, present with abdominal pain, nausea, retching, maybe vomiting, maybe not. Depends on what the operation is and where they're obstructed. But the one thing to point out is I think that the conservative algorithm of an NG tube decompression may not apply, particularly for bariatric patients. There's many causes: adhesive bowel obstruction, incisional hernia, port site hernia, intussusception I mentioned, but the one that we always think about is a mesenteric or internal hernia. This is very concerning, and this is why bariatric patients probably need to have a very say a high index of suspicion for internal hernia. No one wants to take a patient to the operating room and see this. Internal hernia is a closed loop obstruction, so your conservative algorithm is probably not going to apply. 3 sites of common internal hernias after gastric bypass: your Peterson space, your transmesenteric space, and again the retroanastomotic space or your enterostomy defect. There's a little bit of debate as to whether or not these ought to be closed at the time of the surgery, but even if they are closed, the problem can still happen. You can have acute and chronic presentations. In this, for the purpose of this discussion, we're leading with the acute presentation, which is going to be a bowel obstruction. But depending on which segment of bowel is obstructed, they may have varying presenting signs and symptoms. CT scan is your diagnosis of choice, but it can be misleading. It's not 100% sensitive. Don't be fooled by the commentary of the radiologist that the contrast goes all the way through to the colon. If your biliopancreatic limb is obstructed, that is going to possibly be misleading. The classic sign for internal hernia is a swirl sign, which you see on that x-ray. Again, take care of the patient. You're going to explore them, and hopefully you can do it laparoscopically. Usually work, as with any bowel obstruction, distal to proximal. Place the bowel in the right lower quadrant, and only if necessary, handle the dilated bowel. One other one that I'll mention is just intussusception after gastric bypass, which we will see from time to time. The key here is to note that probably the only way to really fix it is to revise the enterostomy. I've seen some attempts at pexing and suturing the bowel together, but that's likely to recur. So probably the best thing to do is simply to redo it. And again, I think that bowel obstruction in a bariatric patient should be handled differently, maybe a little bit more aggressively than your common general surgery patient. One quick word about obstruction with lap band. Again, this at least in our part of the country, the surgery is getting less and less common, but if a band patient comes in with an acute change, vomiting, or even reflux symptoms, that might be indicative of a slip. The test to get is an upper GI. You'll see a big dilated gastric pouch and probably a horizontally oriented band. Those are your keys. The first thing to do, of course, is take fluid out of the band. It is not, unless you're used to doing it, maybe not as easy as you might think. They're big patients. You need to have the proper needle. It's a big, long Huber needle. Make sure your patient is positioned properly, and you can have them do some crunches or Valsalva maneuvers to help you feel and palpate the port. If you can't do that or the patient doesn't improve, you need to take them to the operating room and take out the band. The key is to get to the lesser curvature side. That's usually safe, and you should be able to excise it. And then lastly, one quick word on nutritional problems, which we don't usually think of as an acute problem with bariatric patients. It's more of a chronic long-term thing, but there is one scenario that I wanted to mention that can happen acutely, and we seem to be seeing it more frequently, and I think it's actually one of the, for those of you looking for MOC, one of the questions that may come up later on in the post-test. But this is a common, not common, but this is a scenario. Patient has a sleeve gastrectomy 8 weeks prior. Frequent vomiting, which we do see with the sleeve. It can take a little bit of getting used to for the patients, and they come in having had significant weight loss, not tolerating solid food, and they have a variety of neurologic symptoms: ataxia, vision issues, disorientation, nystagmus. You guys know what this is? Thiamine deficiency. So that's an acute Wernicke's encephalopathy. It's been reported for virtually all of the bariatric operations. It's been reported as a variety of lawsuits, unfortunately, for patients who are misdiagnosed. It can result in permanent neurologic sequelae. So if you see a patient who's in the early post-op period who's having frequent vomiting, if they're not in the early post-op period, we always recommend, if they come in for whatever reason, give them thiamine. It's certainly not going to hurt. I'll draw your attention to this resource. It's available from the ASMBS website. It's sort of an algorithm chart that you can print out or put in your office, put in the emergency room, wherever. It gives you an idea of the sort of algorithm and diagnostic processes for any of the bariatric surgeries. And then lastly, there's really no shame in calling for help. Some of these things are not as simple as they may sound. We talk about band slips. It's very common, but frankly, to undo it and try to redo it can be a little bit more challenging. Even the internal hernias, if you've got big dilated bowel and you've never seen it. So there's a lot of bariatric surgeons around. Probably not too hard to get in touch with one of us to ask a question. So thank you very much. We're going to move on to our next speaker, which is actually Jonathan. He's kind enough to fill in. One of our speakers had a family emergency, wasn't able to make it. So you can talk about the perforation first and then move on to small bowel obstruction? Okay.
Thanks, Greg. Yep. So Chris Machete, who actually comes from the same institution I do, I'm not Chris Machete, had a family emergency. He sent his slides, and I'm going to walk through his talk for you, and then I'll proceed to do the one that I started with, which I prepared, which is for small bowel obstruction. For those of you standing in the back, if you'd like to sit down, there are a lot of seats up front. If you would prefer to stand for a quick exit, please feel free to do that too. I have no judgment on that. Just that you know that they're available, and if you're uncomfortable doing so. Well, we'll start on this path. 10 minutes is an awful short period of time to cover this subject. I'm glad, and so to jump to the conclusion and to jump to the take-home point at the beginning, I'm glad that COSAR started with the slide that showed the different patients, that showed the critically ill patient to the elective patient, because really the take-home point for this whole subject and for this whole session is that patient selection and surgeon experience really drive what your outcomes are going to be in any of these situations. And so as we go through some of the data that's available for some of this, which honestly most of it is retrospective, but we'll see what's been published, and we will make some inferences from that. How do I advance?
You've got to press it hard. No, the green button.
Thanks. So he chose 4 scenarios that he wanted to discuss and bring up for this session. One is the situation of colonic perforation with a colonoscopy. Penetrating trauma, which I'm actually going to skip through fairly quickly because Dr. Smith is going to cover that at the end, perforated duodenal ulcer, and then perforated diverticulitis. And we're going to contrast that to the colonoscopy situation, which, even though it's colon injury, is obviously 2 very different clinical scenarios. So perforation from colonoscopy, it's fortunately very rare, since we're all theoretically going to get one at some point. or more. It occurs in 2 to 15 per 10,000, theoretically, or at least that's what's reported. The most common area is the rectosigmoid area, although it can happen in any area. I'm sure everyone in here is taking care of perforations at every spot. It can happen during any procedure. There are elements of the procedure that make it a little more high risk to happen. If it's a therapeutic procedure, if there's a polypectomy, if there's a mucosectomy, those certainly carry higher risks of perforation. Advanced age carries higher risk of perforation. And the peritonitis risk obviously increases the longer the time from the perforation. If it's seen at the time of the colonoscopy, if you're lucky enough to see it when it happens, and it can be dealt with very quickly, that's a very different patient than the one who goes home and shows up back in the emergency room with peritonitis or gets sicker later in the day. And the delay and the timing certainly drives who is appropriate for a laparoscopic approach to repair to who is appropriate for the open approach. So once you've identified this, how do you go about repairing it? There are series in the literature that describe endoscopic clip repairs. They fail at least a quarter of the time, and they fail for two reasons. If the perforation is larger than the clip can cover adequately, it may not adequately deal with the hole itself, but equally, if it's been any period of time since the perforation, it certainly does not address peritonitis and a septic source from purulence or fecal contamination, because it's all done endoscopically. So those make it a very high risk procedure as far as not taking care of the original problem. Once you have to go to the operating room, what do you do? I think the consensus is if you find it at the time of colonoscopy and you identify it and you go straight to the operating room, if there's minimal contamination, minimal inflammatory reaction around the walls of the bowel, that may be one that is amenable to a straight suture repair, and if you feel comfortable to do it laparoscopically, that can be done that way. Ones that are more than 24 to 48 hours old, there's a huge inflammatory response and already probably significant peritonitis at that point, significant spillage, and those are much less likely to be repaired laparoscopically. Moving on to the trauma scenario, which I said we would do quickly because Dr. Smith is going to cover this in a little more detail, a lot more detail at the end. The question for utilizing this in the trauma scenario is the missed injury rate. If I put a laparoscope in to evaluate an injured abdomen, can I identify all of the injuries and can I deal with them at that point? So there is a learning curve over the course of the last few decades as this has been reported. Dr. Machete had reviewed 13 prospective and 38 retrospective studies, which had a total of 2,500 diagnostic laparoscopies used for that trauma scenario, and there were listed 83 injuries of 3.2%. Over the last decade, the number, as you look at series in the literature, the missed injury rate, which used to be much higher than that, has now dramatically dropped to even where some series are showing 0% missed injury rates. That's dependent on a lot of factors. It certainly is well described that if you're using the laparoscope just to determine if peritoneal penetration has occurred, that we are saving over 50% of unnecessary laparotomies by being able to assess the area with laparoscopy, seeing no penetration, and then the patient leaves with a 1 centimeter incision rather than a stem to stern incision. And we certainly save a lot of morbidity from doing that. Again, reviewing multiple studies done on this in 1,200 diagnostic laparoscopies from the study from World Journal of Surgery, found 597 diagnostic laparoscopies for injury. And this addressed the therapeutic side rather than the diagnostic side of applying laparoscopy in the trauma scenario. Whereas intestinal injuries are rare to repair that way, mostly because of the learning curve and the risk of missing injuries. The most common thing is diaphragmatic repair, which has been reported and studied well and can be very competently done by people who are experienced doing that through laparoscopy. There's a very variable conversion rate based on the clinical scenario, based on surgeon experience. And then how do you repair it once you do find an intestinal perforation based on trauma? Again, it goes to basics of if it's intestinal wall that has a lot of inflammation and there's a lot of spillage, that may, and possibly even ischemic and might require resection, that's going to be one that's going to be much more difficult to do and probably is best served with an open procedure unless you really feel comfortable and the patient really is doing well and doesn't have any of the clinical indications that Kosar talked about at the beginning, which would make him a poor candidate for laparoscopic repair. I'm going to move along because I'm running out of time. Perforated duodenal ulcer. Not a lot out there on this. He was able to find 3 randomized prospective, 5 non-randomized prospective, and 8 retrospective studies. And significant heterogeneity because of the patient's physiologic condition at the time that the repairs were done, the surgeon experience, and even the types of repairs that were performed to do this were variable all over these series. There are also low numbers in each of these series, so making conclusions from any of this was really very difficult. There is a little more consensus on who should not have a laparoscopic repair for duodenal ulcer. And those are the same patients, and you're going to hear this recurring theme over and over again, that patients who are hemodynamically unstable, patients who delay in their presentation because of the contamination, because of the significant inflammatory response around the ulcer bed, patients who have higher comorbidities, are all patients who are going to be much better served, perhaps, with a standard repair rather than a laparoscopic repair. And then surgeon experience makes a difference. You have to be able to offer the same repair with the same outcomes laparoscopically that you would open. And if you can't truthfully feel like you can offer the same technical approach and give the patient the same outcome potential, then that settles the question for you. That should be done in an open fashion. Risk factors for conversion. In those series where conversion was necessary, what drove it? The most common thing that required a conversion was the inability to localize the perforation, which, as you know, even in the best of fields, it is sometimes difficult to see in that area, and then with a big inflammatory response, it can be much more difficult. The size of the perforation, legitimately, the larger the size requiring conversion. Patients in shock, patients who are actively bleeding, that should not be of any surprise to anybody. And then patients with generalized peritonitis. Those are the ones that more commonly require conversion to open repair. Again, the repairs should be the same. The variability in the series that are reported do make some standards difficult to say, but straight repair versus omental patch, omental plugging, the same types of things you would consider for an open perforation. Again, if you can't offer the same procedure and outcome hope laparoscopically, then you shouldn't be doing it open. He made a graph putting these studies together and showing the variables that were looked at in their outcomes. OR time was really no different between the 2 groups of laparoscopy versus open in either the randomized studies or taking all studies together. Analgesic use, as you imagine, and has been studied in many other arenas, is better when you use just laparoscopy. It was not studied in the randomized studies, just in the non-randomized studies. Length of stay seems to be improved over all studies. Return to activity improved, and these are not anything new. These are the standard things we expect from laparoscopy compared to open procedures for any clinical situation. Ileus, at least in those studies, the return to diet was the same for both after the repair. Looking at other complications, really the complications for laparoscopy and for open procedures were the same. You could say that for all studies that this could be a little bit of a selection bias, that you got the better patients in the better clinical situation with a less hostile field to operate in, maybe would be better, but in fact all of them were the same. There was really no difference in the leak rates. The ileus rates, certainly improvement as you would expect again for surgical site infection with laparoscopy, and no difference for abscess rates. Pulmonary complication rates, reoperation rates were the same. Mortality was better for all studies, but not for laparoscopy. So the advantages are not clear cut, except for the standard advantages of laparoscopy versus open procedure. European Association for Endoscopic Surgery actually in 2006 had made a statement saying that they recommended laparoscopic repair based on those findings over open repair, but then retracted that statement 5 years later based on the additional evidence. I'm moving along quickly because I'm a little over time and I want to get to the next subject. So the conclusions: laparoscopy for perforated duodenal ulcer are appropriate with patients with low severity of illness, prompt presentation, smaller perforations, and your comfort level, and the comfort level of the team that you have around you. For 60 more seconds, he did mention that the scenario of perforated diverticulitis and the evolution in views on how we address this has been changing. It brings up the whole concept of damage control laparoscopy, which, not intending the laparoscopy to be a full procedure of a colon resection with colostomy or anastomosis, depending on the scenario, but just in the area where there's either a Hinchy 2 or Hinchy 3, where there's localized abscesses or non-fecal contamination, that there can be a laparoscopic washout, drainage, without doing the full stage procedure, and therefore you take an uncontrolled global problem and make it a controlled local problem. Let the patient live to fight another day. The method of damage control offers these advantages. It confirms the diagnosis. It assesses the need for immediate colon resection based on those things. It removes the diffuse purulence, assesses the status of the perforation, and it controls ongoing leakage with drainage. What to do with the hole? There's not a lot of evidence to mandate a standard with this. Essentially, if it's sealed already, let it be sealed. Small holes, you can consider suturing it, but when it's that inflammatory, it's probably not going to hold that well. And then if they're bigger, again, just go to your damage control abilities to take a global problem, drain it, debride it, clean it up, and treat the patient. And I think I'm going to stop there because I'm way over. So his conclusions were the laparoscopic management is feasible for some patients with acute intestinal perforations. Again, it's patient selection. It's a learning curve for the surgeon, and it's making sure that the appropriate procedures are still done. Okay, I'm going to move along. I should mention he had nothing to disclose. I have nothing to disclose. I'm going to talk about bowel obstruction. So again, 3 goals for these 10 minutes or 11 or 12 minutes or however bad I run over, to discuss the importance of patient selection in achieving the best outcomes, because again, I'll go back that patient selection is it so overrides everything else that we look at. Reviewing the available data on the outcome difference between the uses of laparoscopy and laparotomy in the treatment of small bowel obstruction, and to describe the safe technical steps and a few take-home points about how to approach these patients. Bowel obstructions due to internal hernias from bariatrics or due to external hernias, which you're going to hear talk on next, I've left for those speakers. I specifically am going to address adhesiolysis, which is the lion's share of what bowel obstruction is from. So the first description in the literature of a laparoscopy as in a use for small bowel obstruction is from a gynecologist in 1991, Dr. Bastug. 1 patient, 1 adhesion, cut it and reported it. And since then, the literature initially, and this was in the very early days of the laparoscopic revolution, mostly described in the gynecologic literature for chronic pain and for infertility. But there are studies that started to come out. There's just not a lot of them. And they're mostly, in fact, to that point, all retrospective. To the point where the Cochrane review, the conclusion that when they did their review in 2010 was that there was no conclusion, because there were no published or unpublished, randomized or unrandomized prospective controlled trials to be able to make a statement about this, that there were a handful of retrospective clinical control trials that suggested some of the advantages you'd normally see for laparoscopy, which is shorter hospital stay and mortality reduction. But again, that could be a bias based on the reporting. So we get to a surgical endoscopy report in 2012, 29 studies. This was a review of the literature of the laparoscopic approach to small bowel obstruction, 2,005 patients, and of those, 2/3 of them were completed laparoscopically. A handful were lap-assisted, an even smaller amount were converted for standard hernia repair, and 1/3 were converted to laparotomy. So about 2/3 finished laparoscopically and 1/3 converted to laparotomy. Digging down, what was common about the ones that needed to be converted? Dense adhesions, and I think that's the most common reason that people convert is you get into hostile territory and you don't feel safe cutting through what you're looking at, so you convert to open to feel more comfortable, and I think we've all been there. The necessity for bowel resection, which can come in the form of either making a small counter incision over the area where you need to resect versus the need for a full laparotomy if you're unclear for the extent of how far you have to search or resect. Not able to identify the pathology, that makes sense. You can't leave the operating room till you've done that. And then iatrogenic injury. Their enterotomy rate that they looked at in this series was 6.6%. That's the reported rate. Unclear whether that's the actual rate, but certainly an enterotomy, if it's right there in front of you and you feel comfortable with intracorporeal suturing, it's something that can be done, but that was a reason for conversion in this study. Get to January of last year, a NISQIP study in surgical endoscopy showing 5 years of putting together the words laparoscopy and small bowel obstruction, found 9,600 patients. 15% of those treated with laparoscopic adhesiolysis, conversion rate 85%, or not conversion, but 85% of those were treated with an open repair, so only 15% during that 5-year period, at least in this group, were found to be done laparoscopically. And what was found in that study? Well, the mean operative time was actually a little lower for laparoscopy. You could make the argument, again, that these were the single band adhesions, easy to see, easy to fix. Postoperative length of stay, half, which is what we know about laparoscopy. 30-day mortality rates were a lot lower, but again, you could make the argument that maybe those patients were selected out for that reason. Similar study in August of that year, looking at 4,600 patients with adhesive small bowel obstruction. 919 of them had laparoscopic adhesiolysis, and 3,600 had an open repair, again, about the same breakdown. And looking at mortality rates, 0.8 versus 2.3%, better for laparoscopy. The overall complication rate was 1/3 in the laparoscopic group, and the mean length of stay was half. So I think the conclusions you can make from that is that there certainly appear to be benefits in retrospectively added data, but you have to temper it with the thought that maybe those benefits are real, but they're there because those patients were adequately selected and appropriately given the chance to be taken care of laparoscopically. There was a prospective trial announced in the BMC Surgical Journal that was going to take on a multi-year, multi-center prospective randomized controlled trial. This is an overseas trial. That's primary endpoint is going to be length of stay, secondary endpoints, return of GI function, 30-day mortality, complications, and postoperative pain. And hopefully we'll start getting that type of prospective data so that we don't have to always put down the laparoscopic advantages being to selection bias. So again, there's really not a lot of data. That's what's there. But in practical take-home points, I want to spend the last few minutes of this talking about what you're going to do Monday morning, or more likely Monday night when this occurs. Hemodynamic stability, going back to the opening talk of the day. Hemodynamically unstable patients are not the best candidates for laparoscopic repair for all the reasons that you heard. When not only are being able to tolerate a pneumoperitoneum with the hemodynamic changes and the ventilatory changes that occur from that, the timing of the procedure, and that's really based on your skill level and how severe the abdomen is going to be for the patient. But hemodynamically unstable patients are not good candidates for this. Prior procedures. If you have a patient who has one small abdominal scar and there's a chance that there's a small amount of adhesions just related to that, that may be a better candidate than the one that's got 10 railroad tracks going in every direction and has a frozen abdomen, and maybe that's not the patient to try laparoscopically. Clinical exam, if they have a tense peritoneal exam from obstruction, or if they have peritonitis, those are not good candidates to start laparoscopically generally. The likely pathology, if you think it's related to a cancer, or if you think it's a distal obstruction where the entire small bowel is going to be dilated and you're not going to have good domain inside the abdomen to be able to see or safely move around, those are going to be patients that may not be the best laparoscopic candidates. And then the experience of the surgeon and the surgical team, I put both down because you can be a laparoscopic wizard, but if it's 2 a.m., and you have the relief orthopedic team, and they don't, which happens to all of us, happens to me, and they're looking at both ends of the insufflator. Move on. Do the safe thing. So use your judgment with that. Technical points. What do you do with this patient? You've made the decision that they're a good laparoscopic candidate based on those features. preparation. You saw the conversion rate, and that's not because I'm sure that a lot of that conversion these are reasonably safe surgeons doing this, and they did it for legitimate reasons. That conversion's not failure, and I think 25 years later, we still somehow think that conversion from laparoscopy to open represents some sort of sigh and let the air out of the room enthusiasm, but sometimes that's the safe thing to do, and so be prepared to go open, because most of them do. Have the open equipment in the room ready to go. Don't be at the table where you have a pneumoperitoneum, you have an enterotomy, you're in a hostile abdomen, and now you're asking for the open equipment, and your staff has to go run down the room and start getting everything together. Consent. The patient has to know that I'm going to try this laparoscopically, but there's more than a reasonable chance you're going to have an open procedure. Don't make them disappointed when they wake up and you've used the 100-millimeter port on them, because they need to know that. Positioning. Tucked, supine, and strapped well to the bed with good padding. If you're going to do this from start to finish, that patient's going to move a lot. Typically, and we talk about approach, as with open bowel obstructions, at least for me, probably true for most of you, you're going to put that right side up, Trendelenburg, so that you can elevate that cecum, find the terminal ileum, a reliable decompressed area of bowel, and march your way back. And then you don't know where the positioning is going to take you, but make sure that that patient is movable. You're already working in a less than adequate abdominal domain with a hostile area. Have the positioning working for you so that you can have bowel fall away from the area. So the patient has to be positioned well. The abdominal entry, totally beyond the scope of this talk to argue about Verey's needles versus open entry, although with dilated bowel and a tense abdomen, I'm an open entrant anyway, routinely, and I would really advocate for the use of putting the Verey's needles away for getting into these abdomens. We talked about the approach. Finally, just judgment. I'm running out of time, so I'll go through these last few points quickly. You should be making progress. You should be moving through to, if you looked at the same window, the same piece of bowel for 15 minutes and nothing has progressed and nothing has happened, you need to do something, whether it means we use usually 3 to 5 ports to do this. Move your camera around a lot, move your angles around. If you're not happy with the area that you're cutting, go somewhere else. You should be able to see through anything that you cut, obviously. I'm talking to an experienced audience. But you have to be making progress. If it has stopped and you're frustrated and progress isn't being made, that's, as we all know, is where bad things start to happen. That's the time to either change your view, change what you're doing, or change your exposure. And then there's that moment of truth. You got to just be willing to make that decision, and it's not a failure. I think I'm done. So consider converting if bowel diameter is greater than 4 centimeters and you've lost too much of that abdominal domain. It's a distal obstruction where the entire small bowel is that dilated and you have no domain to work in. The small bowel is matted and you're going to be at a higher rate for anerotomy. Dense adhesions where it's just difficult to see where your planes are. Perforation or necrosis where resection may be necessary and laparoscopic approach may be difficult. And if you can't see, you can't move. So my take-home point is the laparoscopic approach to adhesiolysis is appropriate in selected patients, has consistently shown benefits in those retrospective studies, but it's all related to patient selection and to your comfort level as a surgeon and a team. Sorry I went so over. Thank you.
Thanks very much, John. Actually, we'll take, there's been some interesting questions. Keep them coming. One question for you. It was asked whether in repairing a perforated duodenal ulcer, would you place a J-tube at the same time? And if so, would you put that in laparoscopically?
I'm not a huge fan of laparoscopic J-tubes. I'm an enthusiast for doing anything laparoscopically where the patient's going to see a benefit. I've found, and maybe it's just me and the way I put them in, but I've had issues with leaks and complications from laparoscopically J-tubes, and it may just be the technique that I use. I think that for patients who have bad perforations, who have peritonitis, who it's clear they're going to not be, or if the diameter is large from the ulcer, then I am a fan of enteral feeding and early enteral feeding, so I would place one.
All right, thanks very much. We'll get moving along. I'll invite our next speaker up. It's Dr. Brian Jacob from Mount Sinai in New York. He's going to speak to us about the use of mesh in the acute setting or in acutely incarcerated hernias.
Thank you, Greg and John. It's great to be here, and Greg, thanks for giving me the one talk where there is no correct answer. But it's an interesting topic that we all face, and we never face this at the time of the day where we want to. And you know, one of the things that makes this answer challenging of whether to put mesh in a strangulated scenario or not is we know that mesh can get infected. We also know that mesh can get infected later on during recovery, and when that happens, it can erupt as a fistula. So you don't want to see either of those two outcomes just because you decided to fix a hernia with mesh at the time that the patient was suffering from a strangulation. Because then you end up with this scenario where you've got bowel and mesh entangled, and you're trying to figure out what to do, and the next thing you know, you're even resecting more bowel. So incarcerations and strangulations come in many different shapes and sizes, and I try to teach this as often as I can, but when you see this scenario, you just have to go back to the basics and ask yourself, what are you looking at when it comes to the level of contamination? Is it still a clean case? Is it a clean contaminated case? Is it a infected field or a contaminated phase? And so you have to really go back to that scenario whenever you see this situation. If you think it's a clean case, in other words, if you watch that bowel that's stuck there in a femoral hernia and you think that you're able to leave that there, then there's no bacteria, and you can actually go ahead, especially because you're in a different plane, and fix this with a mesh product. If you're not comfortable using a synthetic piece of mesh, you can put in a partially absorbable mesh, but you can actually go ahead and put mesh in this scenario. You don't have to. Doesn't mean it's the right answer, but it is an option for you to do so. And so in that particular case, we actually went ahead and did an extraperitoneal repair, resected the hernia sac, and then went back. And this to show you what the bowel looked like later on. I think you'll all agree that this thing was pinking up quite nicely and had a chance of recovering. So you have to ask yourself what you're doing. When I talk about the CDC classifications, you really have to just put to memory clean, contaminated, or dirty and infected fields, because I think your choice is going to fall into that category. And when you have to ask yourself what you're going to do, you're going to base your decision on a few different things. You're going to base it on what you're comfortable doing, what you think. And some of you are going to go to the literature and look it up, but we don't have to make all of our decisions based on literature. Sometimes you're going to ask a colleague, what would you do in this scenario? And so you're going to put all that together to make your situation. So this is a friend and colleague, I don't know if he's in the audience, Dr. Ed Felix, shared this video on our website. This is an incarcerated perforated appendicitis in an umbilical hernia, which he approached laparoscopically. And you know, he stops it at this point and asks you what you're going to do after you reduce that appendix with perforation and pus. How many are going to close that primarily? How many are going to put a retrorectus large pore lightweight polypropylene or Reeves? How many are going to put in biologic? I got one. Okay. So this video was from about 4 years ago. And he put in biologic, and this patient actually did fine. I'm sure the biologic eventually disintegrated. There was no abscess, there was no fistula that developed, and the patient did okay. But you can see the trend where maybe 3 or 4 years ago this was something that everybody would do. And now your decision is different. Why is there a variation in our decisions? A, there's no great data to lead us, and 2, they're more than one right answer. So there are different options. Now what about this scenario? This is a small, tiny hernia. It's a trocar site hernia where the people who admitted the patient, me, sat on it for about a day. And then you go back and you see that the patient is obstructed from a trocar site hernia. By the way, this is a 5mm trocar, so it can happen. That dilates out, so those who don't believe it can, there it is. And that bowel is not happy. That's all fibrinous exudate there. That needs a resection. So the question is, how do you fix that hernia? And for me, that's a primary repair, but you also are now going into the clean contaminated situation. So what does the literature suggest? First question is, what happens to mesh when it mixes with bugs? All right, and you can look into literature and look for all the different studies and the different types of mesh. So you got silver impregnated meshes, you got biologic meshes, and you can't see that because it's small, but you've got vicryl meshes, and you've got polypropylene. And the long story short, if you can imagine, is that they all can get infected when mixed with bacteria. And this study was done with 96 rat inlays. But then you say to yourself, well, what's an inlay? Well, an inlay is when you take mesh and you suture it to the perimeter of a hernia defect, which means what? Well, you don't have any tissue ingrowth on either side of that mesh product. So if you take a piece of mesh and you just bathe it in bacteria, of course it's going to get infected. But when you ask the host that you're implanting it in to do something different, to heal around it, and give it a chance for fibrous ingrowth, well, then you've got a chance of something different, because what causes a mesh infection? Biofilm. You have to have biofilm form around the mesh fiber for to have a chronic mesh infection. So if you can prevent the biofilm from forming, even in the presence of bacteria, you're not going to have a chronic mesh infection. So the question is, does the mesh location matter in that scenario? Now again, don't want to put mesh in, don't put mesh in, but this is just food for thought. So does the location matter? Again, thinking about the fact that an inlay has no tissue ingrowth. So when you look at the differences between tissue ingrowth and the places that you can put mesh, and you study this scientifically, you realize that the body actually does react differently to those different layers. And the long story short in this particular study is that the difference between an onlay and an inlay is a 3 times more type 1 collagen formation in the retrorectus space. There's that much more wound healing occurring in the retrorectus space as opposed to an onlay. So there is a difference in the cellular activity between where you put the mesh products. Synthetic materials are evolving to accept this concept, so they're less dense, they're lighter weight, and they're more large pore. And the other thing is there's a plethora of literature out there to support the statement that some monofilament, large pore, polypropylene-based meshes clear bacteria at the same rates as the biologics. And this came out, and this really changed the game for all the people in the biologic world, because suddenly you didn't have to spend so much money and you could probably get the same result. Now that's not true for all meshes, and some biologics are better than others. But Alfie Carbonell decided to study this. So in 2009, he had this concept that you could actually put large pore, lightweight polypropylene in clean contaminated and contaminated fields and get away with it, or at the very least, have no difference between the biologic products. So he set up a study, and they did a prospective study of 100 patients, which you can see here. And what I just highlighted in this article, and this is in JACS, so you can look it up, 2013, but they had 27 incarcerated hernia patients with either clean contaminated or contaminated fields. And this is their breakdown. So there was 0 clean cases, 42 patients were clean contaminated, and 58 were actually contaminated. So this is a true population. If it was a complete ball of pus, they didn't do it. So clean, contaminated, and contaminated. And you can see here that the reason for those classifications were mostly due to violation of the GI tract, or it was an ostomy creation or reversal. They used lightweight polypropylene synthetic mesh in all the cases. For those that don't know the different products, there's 3 common ones on the market, 2 by Ethicon, 1 by Davol. They're called Ultra Pro, or Proline Soft, and then Bard Soft Mesh. And these are all lightweight, large pore polypropylene meshes. And how they used them, and you can see most of these were done in the retrorectus space. And that's an important detail of the paper. So you don't want to take a data and then extrapolate and say you can do this with an onlay or a laparoscopic placed mesh. This is retrorectus, because as I told you, when you have tissue ingrowth on both sides of the mesh, it changes the game. And what did they see? So what they saw is in the surgical site occurrence, this is anything that can happen to a wound, including seroma and anything else like that, not just wound infection. There was 11% in the clean contaminated cases, and in the contaminated cases, there was a 20% surgical site occurrence rate. What was more interesting is when they looked at the infection rate. So this is just wound infections or from the surgical site infection rate. Within the first 30 days, you can see that the clean contaminated had only 3%. And in the contaminated, remember the contaminated one's real dirty, 7%. Well, guess what the biologic literature showed? Same numbers. So there was no significant difference. And of course, when they looked at recurrence down the road at 6 months, the recurrence rates were not that high. And they didn't have to go back and take out many meshes at all. So the literature does exist to support the use of lightweight, large polypropylene in the retrorectus location in clean contaminated cases. But again, this is literature. It doesn't apply necessarily to you. It took 5 years to get the message out. And probably, as you saw, none of us are doing it anyhow. But there's data out there to support it if you chose to do it. So really is out there is if you have this scenario and you want to know what would your peers do, how do you get access to that information tonight? Or today. And again, some of you out there may have heard of the International Hernia Collaboration, some of you may not, but there's a giant social media group called the International Hernia Collaboration that we started. We're now up to 1,200 surgeons on the group where you can get answers kind of quick. So we were debating this exact topic, coincidentally, where we polled the audience and we said, look, if you've got a strangulated hernia, this was asked by David Chen on April 9th, and the thoughts from the group would be appreciated and they'll credit the IHC. And the choices were open with suture alone, open with mesh, lap with mesh, and biologic. And this is the answers that they got. You can see that 43% would just do open with suture alone, which sort of represents the majority. And the rest would do open with mesh, 23%. And laparoscopic is still 29% and only 3% biologic, which is about the same. So do you need to spend $4 million in 5 years to get an answer, or can you just poll an audience and get a similar answer of what's going on? I don't know. But the question now is, what are you going to do in that scenario? Intraop strangulation, remember, assess the contamination level. Are you really dealing with a clean field? If you are, you can go ahead and fix that. If you're going to stage it, repair it now. They're both acceptable. Both have risks, so tell your patients that those complications of mesh infection and fistulas are risks if you're going to put mesh in. And then where you're going to put that mesh and which product you're going to use do matter. So when you just say to that orthopedic staff in the middle of the night, give me the mesh that's on the product, you do have to make sure that it's a lightweight, large pore polypropylene in order to fit into that cohort of patients that they're going to do well on. And that's about it. Thanks.
Thanks very much, Brian. And we'll move along. Our next speaker is going to be Dr. Jonathan Pearl out of the University of Maryland. He's going to talk to us about laparoscopy and pregnant patients in the acute care setting.
Thanks. Good afternoon.